Assalamualaikum and good day everyone. I'm Zahid from IJN. So today I'm presenting my research. So my topic is outcome related to the timing of IBP insertion in CABG surgery. So Prof. Ezani and Prof. Alwi are my supervisors. IBP, as we know, is the most common mechanical support device that we use in cardiac surgery. Was reported to be used in between 5 to 10% in all cardiac surgery cases. There is ongoing debate on the timing of IBP insertion, whether should we put it pre-operatively or intraoperatively in carefully selected patients. This is because IBP itself is not without complication. In an unfortunate event, it can lead to mortality and other complications such as severe vascular limb ischemia that lead to amputation and so on. My research question was, does the timing of IBP insertion affect the outcome in CABG surgery? So this is my null hypothesis. There is no difference in outcome. Meanwhile, my alternative hypothesis was there is significant difference in the outcome between pre-operative and intraoperative insertion of IBP. So the purpose of this study was to assess the association between the timing of intra-aortic balloon pump insertion and the outcomes in patients undergoing CABG. This is a retrospective observational analytical study in patients who underwent isolated CABG surgery who required IBP pre or intraoperatively in IJN across 5 years period from the 1st January of 2016 to 31st of December in 2020. So patients were divided into two groups depending on the timing of IBP insertion, whether pre-operative or intraoperatively. So we included all adult patients over the age of 18 years old who underwent isolated CABG who received IBP insertion pre-operative or intraoperatively. So for those patients who are having existing kidney disease, existing rhythm abnormality, existing neurological impairment, and existing gastrointestinal diseases prior to surgery were excluded from this study. So these were the variables or baseline characteristic measured, including the patient's socio-demographic status, angina status and failure status, comorbidities, smoking status, ejection fractions, CPB and cross-clamp time, and extubation times. We measured the primary outcomes including new post-operative cardiac arrhythmia, post-operative stroke, AKI requiring RRT, gastrointestinal ischemia, limb ischemia needing amputations, extubation time, length of ICU and hospital stays. These were measured as the morbidities. Meanwhile, my secondary outcome measure was mortality rate. So a total of 7,551 isolated CABG were performed in IJN during these 5 years periods. So based on the exclusion criteria, 7,258 patients were excluded from this study. Hence, a total of 293 patients were included and further divided into pre-operative IBP, which was 195 patients, and intra-op IBP, which was 98 patients. The patient socio-demographic status and pre-operative data are shown in this table. So out of 293 patients who received IBP, 87% of the patients were male patients with a mean age of 61 years old. So among those patients who have angina pre-surgery, majority of them are classified as class 2 according to CSS classification. Meanwhile, among those patients who have dyspnea or failure symptoms, majority of them were classified as class 2 according to NYHA classification. Basically, the preoperative risk factors or risk profile were comparable across these two groups, and patient and pre-op IBP patient had a similar degree of left ventricular ejection fraction compared to intra-op IBP group. We can see from this table, the intraoperative IBP group had a significantly longer bypass time compared to the pre-op IBP group, with a mean duration of 120 minutes in intra-op IBP and 106 minutes in pre-op IBP group. However, there is no difference in the cross-climb time across these two groups. This graph are showing the primary outcome result. So in overall, There were no significant difference in the outcome in terms of the renal complication requiring RRT, gastrointestinal complications, limb ischemia requiring amputations, stroke, arrhythmia, duration of extubation, whether it is less than 12 hours or more than 12 hours, and length of hospital stay, where the p-value was more than 0.05. However, pre-op IBP group had a significantly lower mean duration of length of ICU stay when we compare to intra-op IBP group with a p-value of 0.011. This means that patient with pre-op IBP stays shorter in ICU compared to intra-op IBP group. This graph showing the secondary outcome results from this study. However, after the analysis, there was no significant difference in mortality rate compared to intra-op IBP with a p-value of 0.559. From this study, according to the research, there are no significant difference in the primary outcomes among those IBP inserted prior or intraoperatively. However, the study did demonstrate a reduction in ICU length of stay, which may contribute to further lowering the risk of ICU-related complications. Again, the mortality rates as the secondary outcome were likewise comparable across the two groups. The study limitations is that this is a non-randomized trial, but rather a retrospective observational study in a single center. Hence, it lack of generalization and exposed to bias. These are my references.